All right. Good afternoon, everyone. Welcome to my Gran rounds, the last one of this year. I'll try to keep it quick and short as much as possible. If there's any questions, please feel free to ask me again. Probably nobody has questions also, but we'll see. So my topic is hypertensive disorders of pregnancy. The reason I picked this topic is obviously from personal experience, having gone through it pretty recently myself. I was in the hospital and I remember emailing Dr. Lucci frantically, trying to see, are they managing it well, Dr. Lucci? Are you sure they're doing the right thing? I almost wanted, I kept asking her, do you think they're overreacting? Do you think this is white coat hypertension? And it actually, I was surprised at how little I knew about the topic itself, though we hear about it since med school and we learn about it. We think, oh, this is a really easy topic. Just starting with the definition of preeclampsia itself, started me because I always thought hypertension with proteinuria equates to preeclampsia, but apparently not. Just having hypertension with a certain cutoff, you qualify for preeclampsia, which was new to me. Probably people here know that, but it was new information for me. And I asked a couple of fellows too, and they were like, yeah, we didn't know that either. So that's why I picked this topic, just to quickly review over it. The reason why this is important to every clinician is because of how often we encounter pregnant women in the clinic. And usually when you see pregnant, people get scared. I went to the urgent care just for the flu and she was like, you're an alien, I have to look this up. She just needed to test me for a flu. So I feel like hypertension is something that we as nephrologists deal with all the time. And then combined with pregnancy, it's something that's often seen and it's good to just quickly review it. Also, it's one of the major causes of morbidity and mortality in the world right now in pregnant women. Over time, the prevalence has gone up mainly because of urbanization and its associated changes like sedentary lifestyle, advanced maternal age. Now people get pregnant at a later age as compared to the olden days. Use of assisted reproductive technology, high BMI, all of these actually contribute to you having hypertensive disorder. The mean age, like I was saying, is higher now when women get pregnant. So when this is a graph from CDC that I looked at. From 2004 to 2014, when they looked at the birth orders, they saw an increase in the age at which people had their first birth, and the highest increase was seen in the first birth of when they had it. It went from 24.9 years in 2000 to 26.3 in 2014. And then again, in the next decade, they saw a similar incline in the rate from 26.6 in 2016 to now 27.5 in 2023. So we see that more and more women are getting pregnant at a later age. Why this is important is because once your age goes up, your risk for other comorbidity goes up, and then you're at higher risk for having hypertensive disorder pregnancy. The definitions, like I was saying, this is just a quick review of that. Chronic hypertension, as we know, is systolic more than 140, diastolic more than 90 when checked on two occasions 4 hours apart, but usually when it's present before 20 weeks of gestation. Gestational hypertension is when you have the same criteria, but you see it after 20 weeks of gestation. Now, preeclampsia is actually categorized as under two categories, which is without severe features and with severe features. In without severe features, it's the same blood pressure cutoff of 140 systolic, 90 diastolic, 4 hours apart, 20 weeks, after 20 weeks. But they also, the presence of proteinuria more than 300 milligrams in 24 hours. But the one that is with severe features was more interesting to me because I didn't know about that part, where you can have the above along with end organ damage, which is okay because it includes the proteinuria, but just having a systolic more than 160 or a diastolic more than 110 on two occasions that's 4 hours apart actually qualifies as preeclampsia. Or if you have the same blood pressure of more than 160 systolic and diastolic 110, and you're trying to bring it down with IV med, but it's persistently staying high, that also qualifies as preeclampsia with severe features. And then eclampsia, as we know, is the same with seizures. Hypertensive disorders in pregnancies complicate about 13 to 15% of pregnancies in the US. And in this, preeclampsia affects almost 2 to 8% of pregnant women, which is a pretty good number. The hypertensive disorder accounts for 7% of the maternal deaths in the US itself. And the incidence has actually gone up from 529 in 10,000 deliveries in 1993 to 912 in 2014. This is more prevalent in the undertreated it's more prevalent and undertreated in pregnant women of the lower socioeconomic status, mostly because they have poor access to healthcare. And also, when they, according to NAFSAP, it says that there's increased risk in non-Hispanic Blacks as compared to non-Hispanic whites. I know that this also has a contribution from the social status and the access to healthcare again. There is single center prospective study screening more than 10,000 postpartum women and detected this new diagnosis in 8% most frequently Black women with a higher BMI. The short-term adverse outcomes that they saw from preeclampsia included them undergoing C-section, having a brush-tube placenta, prolonged stay, hospital stay, increased maternal mortality. And in those who had preeclampsia less than 37 weeks, there was an 8-fold increase in the pregnancy adverse outcomes that were mentioned above. The long-term effects include ischemic heart disease, and actually in patients who have preeclampsia in the first 12, they have almost double the risk in the first 12 years after pregnancy. Patients with preeclampsia after 37 weeks also have a 2-fold increase in the long-term cardiovascular events overall. And there's data that says that as the age progresses, there's obviously increased risk, but there's not enough study to establish its association with like major cardiovascular events. This is just a graph that compares the reference group along with those with hypertensive disorders of pregnancy. And if we see the risk of hypertension later on, meaning chronic hypertension, coronary artery disease, stroke, everything is higher in this population as they age more and more. And all of that was statistically significant. Just hemodynamic changes that occur in normal pregnancy when there's increase or surge of estrogen, progesterone, and relaxin, there's release of nitric oxide, which causes systemic vasodilation and decreases in systemic vascular resistance. This reduces the perfusion to the kidneys, activates the RAS mechanism. There's salt and water retention and volume expansion. Overall, there's increase in the volume status of these women because it's increased. Due to this, there's increase in the stroke volume because there's physiological anemia because of hemodilution. That further causes the heart rate to go up, and overall, there's high cardiac output. Also, there's increase in the arterial and venous capacitance, more so in the first trimester, where we see that the MAP drops by 8 to 10 millimeter from their baseline initially, and then at 16 to 20th week, it reaches its natty, and then it goes up by the 40th week, where it goes to pre-pregnancy state. So you might actually see a lower blood pressure than their true blood pressure in the first trimester, especially at 16 to 20 weeks. The pathophysiology in preeclampsia itself, earlier they thought that it mainly occurs because the plasma volume is reduced in these patients. But recent studies show that it's actually an overfilled circulation where there's increase in the plasma volume, but it's not vasodilated like normal pregnancy, more so vasoconstricted, which causes the blood pressure to go up, suppresses the renin, lowers the GFR, and causes edema. GFR is overall 30% less than normal pregnancy due to decreased renal blood flow and endotheliosis in the glomerular capillary bed. And women who already have hypertension, diabetes, CKD, they have much higher risk because they have endothelial damage to begin with, and then they have pregnancy which further complicates it. Additionally, in pregnancy, we see more insulin resistance, overall cholesterol, lipids go up. Patients with preeclampsia have it more pronounced than normal pregnant women. Also, hypercoagulability is a feature of pregnancy which we see so that there's less hemorrhage during delivery, but this also gets exaggerated due to increased thrombin, fibrinogen, activated protein C resistance, and reduced protein S and fibrinolysis. One of the main things that happens in preeclampsia is abnormal placentation. In healthy pregnancy, the trophoblasts, they invade the spiral arteries and they replace the endothelium, thus causing thinning of the vessel wall. And this is known as pseudovasculogenesis. That actually leads to these vessels having high capacitance and being more vasodilated, which have lower resistance and thus will increase the placental perfusion. But this remodeling does not happen in patients with preeclampsia, due to which they have a higher resistance in the placental vasculature itself, which causes placental hypoperfusion, ischemia. And then this ischemia leads to oxidative stress, and then there's a widespread endothelial dysfunction overall in the body, which is mediated by angiogenic imbalance and an inflammatory reaction. the ischemic placenta itself releases something called a soluble FMS like tyrosine kinase 1 and soluble endoglobin. Why this is important? Because they are anti-angiogenic, which goes against what happens in pregnancy usually. These go and bind to VEGF, vascular endothelial growth factor and placental growth factor, and actually they act like a decoy receptor and prevents the VEGF and the PIGF from interacting with their own receptors, thus antagonizing the pro-angiogenic function, which I described about the vasculogenesis. Thus, overall, and then it spirals down and leads to multi-organ dysfunction. This starts with intolerance to fetal antigen, why this occurs in the first place. Due to maternal immunological intolerance to the fetal antigen, it may contribute to abnormal presentation. So that intolerance itself leads to what was described earlier. This can happen when they have lower exposure to paternal antigen. For example, they're pregnant for the first time. They've never been exposed to this antigen. So that can start the process itself. But also just having longer intervals between pregnancies can lead to it because now they're not exposed for a long time and now it's almost like a new antigen to them. Or conception from oocyte donation or intracytoplasmic injection. In preeclampsia also there's relative deficiency of regulatory T cells, which promotes immunological tolerance in normal pregnancy. There's also increase in the natural killer cell activity, which recognizes HLA, which is expressed in these extravillous trophoblastic cells. So this combined with the increased dendritic cell infiltration into the preeclamptic tissue actually leads to abnormalities, which are very similar to when you basically reject an organ that was transplanted. But there's no definitive evidence that supports the HLA alleles in the pathogenesis of preeclampsia. And then this is just an overview of what I just described. So the extravillous trophoblast remodel the spiral arteries, which causes their capacitance to go up, mediated by VEGF and the placenta growth factors. Mainly occurs in the first trimester. In preeclampsia, there's failed placental remodeling. There's ischemia, which leads to those the soluble FMS like tyrosine kinase 1. And endoglobin, which works against the VEGF and the placental growth factor, prevents them from binding to the receptors and leads to endothelial dysfunction, lower antioxidants, lower nitric oxide, increased vascular resistance, more ischemia. When it occurs before 34 weeks, it's mostly mediated by the placenta, but if it occurs after 34 weeks, it could be the maternal cardiovascular, like her risk factors to contributing to it. Acute atherosis is another thing that we see in patients who have severe preeclampsia, where the spiral artery has lesions which have foamy cells and fibrinoid atherosis. This is usually similar to what we see in atherosclerosis, but happens more acutely as compared to chronic, where we see that in patients with atherosclerosis. Moving on to the risk factors, there's high risk factors for preeclampsia and moderate risk factors. So the high risk factors are anyone who had prior hypertensive disorder in the previous pregnancy are always at risk for it. Preeclampsia in the previous pregnancy, again, it's the same thing. If they have multiple gestation, like twins or triplets, they're at higher risk. If they have chronic kidney disease to begin with, they're at risk. If they have lupus, antiphospholipid syndrome, then they also are at risk for it. Diabetes, type 1, type 2 diabetes, chronic hypertension, and if they have many of the moderate risk factors, there's more than one of the moderate risk factors, again, that makes them pregnant. Moderate risk factors are being pregnant for the first time, age more than 40, interval between pregnancy for more than 10 years, having a BMI more than 35, family history of preeclampsia, multifetal pregnancy. I don't know why that's in both, but complications in prior pregnancy, like low birth weight, patients who have had IVF, Black race, and low economic status. Now, preeclampsia and CKD. So this was a study by DuPont where he looked at mice, so not humans, but they looked at nephrectomized mice. And usually in patients or in pregnancy with two kidneys, there's increased GFR, increase in the plasma volume, which increases the placental perfusion. And there's something called as L-kynurenine, which goes up in these patients. There's modeling of the spiral artery, healthy placentation, normal blood pressure. In patients who have already like reduced kidney function, you wouldn't see an increase in the GFR to the degree that you see in a normal patient. And the plasma volume also doesn't go up as much as a normal patient, because of which the placental perfusion goes up, but not similar to what you would see in regular patients without preeclampsia. Whole mechanism, everything, the L-carnitine doesn't go up as much, which leads to the blood pressure being high, proteinuria, and maternal preeclampsia. And the impaired placentation again causes the high placental SFLT1 production. In a systematic review of about 13 studies, they looked at the adverse maternal outcomes, meaning all of that we described earlier, in patients with CKD. And among 2,682 pregnancies in women with CKD, there were 312 adverse maternal events, which is about 11.5%. While in patients without CKD, it was a bigger number, 26,149. There were only 500 events in those, thus telling us that CKD definitely is one of the major risk factors. This was one of the papers that also looked at pregnancy after kidney donation. In this large survey, they looked at previous living donors in a single center and looked at the fetal and maternal outcomes and the pregnancy outcomes after kidney donation. They saw that after they donated the kidney, if they got pregnant, their outcomes were pretty similar to the general population, actually. But when they compared women who had a kidney donation after being pregnant versus those that had donated a kidney before being pregnant, they saw worse outcomes in patients who had already donated a kidney that lost some renal mass, and that's why they had CKD to begin with.
One more time, I'm sorry.
So as compared to the general, so in women who got pregnant after they had donated a kidney, when they compared them to the general population, the outcomes were not different. But when they compared those people to women who donated a kidney after they got pregnant, then they obviously saw better outcomes in those. But I think that's just saying that I know there was confounders because they almost qualify as the regular population when they donated after being pregnant. Talking about chronic hypertension and pregnancy, some of the diagnostic challenges. Like I mentioned that the blood pressure usually dips at 16 to 20 weeks. So sometimes when they present at that point, if you see the blood pressure, you might think that, oh, this is probably normal, and you may not recognize chronic hypertension because you don't have a baseline on them. And later on, when they start rising, you might think this is new onset preeclampsia now. But it's always safer that you treat it as new preeclampsia rather than doubting whether this is chronic hypertension, because then you have more stricter guidelines in treating those patients and it's better outcomes. When do you suspect superimposed preeclampsia in patients who already have chronic hypertension? When you see a sudden spike in the blood pressure in people who are previously controlled, they have new or sudden worsening of their proteinuria. They've development of classic symptoms like headache, epigastric pain, visual changes, or they have target end organ involvement like thrombocytopenia, liver dysfunction, or elevated uric acid levels. This is again just a graph of looking at the cardiac output, what it does in the different trimesters of pregnancy, which I already described before. So this was one paper that was looking at identifying preeclampsia using certain screening components and using it to enable timely initiation of aspirin prophylaxis and targeted antenatal care in women. So what they did use for screening was at 11 to 13 weeks, they looked at certain maternal factors like age, BMI, their medical history, and all the risk factors that I described earlier, and also some biophysical markers like the MAP, uterine artery pulsatility index, which is basically using a Doppler to look at the blood flow in the uterine artery. And above a certain number, there were different cutoffs for some studies. The higher the number, the higher the resistance and more the risk of preeclampsia. And they also looked at some biochemical markers like placental growth factor and the PHCPA, which is usually released during pregnancy. Using all of that, when they compared just maternal factors, meaning just looking at the risk factors and trying to see if they can treat those patients, it had about 58%. And they were able to identify about 58% of patients with preeclampsia before 34 weeks, with a 10% false positive rate. But when they combined the maternal factors with all of the other, the biophysical markers and the biochemical markers, they actually got up to 88% positive, meaning they were able to identify almost 88% of the patients with preeclampsia and only a 10% false positive rate in those. Diagnosis, I kind of went over this, but for preeclampsia, again, the blood pressure was 140, 90, 4 hours apart with someone who had previously normal blood pressure, or more than 160, 110, confirmed over a shorter interval of period. So usually it requires 4 hours, but when the blood pressure is that high, even a shorter interval is enough, because then you have to initiate antihypertensive faster, along with proteinuria of 300 milligrams. If you don't have proteinuria, then you need to have at least the target end organ damage, like thrombocytopenia, platelet count less than 100,000, renal insufficiency, impaired liver function, pulmonary edema, and new onset headache, which is not responding to the medications. Again, preeclampsia with severe features doesn't require that. You just have a blood pressure 160 or 110 on 2 or more occasions 4 hours apart, or you're trying to treat it with all the IV medications, but you're not able to bring it down. And then we spoke about gestational hypertension, chronic hypertension, and those with superimposed, so I won't go over that again.
Can I ask you a question on the blood pressure? So I know most of the time they are doing blood pressure in clinic, so that's why it says more 2 readings 4 hours apart. And maybe in the population wise, most of the time we get clinic pressure. But in general, we know that home blood pressure is better marker. We can't do ambulatory blood pressure, but it's always better. But how about following daily home blood pressure, get an average of a week and check it every week? Has anyone looked at it for preemptive, like how they looked at other markers?
If I saw that, but I would think that it might delay your management or intervention, so.
Or for diagnosis, like early diagnosis. Like why wait for clinic appointment to see one more than 160 if you're doing every day?
Right,
Could you catch it early?
so you mean like even before you see that 160, just as a prophylaxis of checking?
To risk stratify the patient.
I see, I don't think I found anything like that, I think,
That's okay, I'm just
yeah.
curious, why not?
Right.
Certainly,
I
they
would
recommend it I recommend all
Yeah.
patients to check blood pressures at
Yeah.
home. And if they see any spike to be visited, and you're right, the blood pressure at home is much less than 140.
Right,
It's in the 110s.
yeah. Actually, yeah, that's true. Most like even for me, when they told me to check it every, just looking at the risk factors, I think they tell all the patients to do it. I just don't know if it's studied to look at if that has.
Yeah, what number, like what
Right.
number,
Yeah.
you don't have to have 160 at that time or 140. The
Usually
home
not.
average is gonna catch it earlier than a clinic measurement one time. Anyways, I was just trying to say if it was
Right,
something looked into.
There's very little research actually done in pregnant women, surprisingly.
Yeah.
And even look at, when you think about what the optimal blood pressure for them.
Right.
Obstetricians are so afraid of over treating
Yeah.
blood pressure because of hypoperfusion of the fetus. And yet the data for that is not very strong at all.
because even ACOG guidelines gives you when to treat, but it doesn't tell you when to stop, like what is your target? It only tells you where you have to treat it.
Yeah.
So these were the angiogenic markers I was talking about earlier, which is the the soluble FMS like tyrosine kinase 1 or the soluble endoglobin. These basically go up in patients with preeclampsia, and they have anti-angiogenic effects by blocking the VEGF and the placental growth factor receptors. The changes usually precede the clinical symptoms and correlate with the severity of the disease, meaning that you might see this even before the patient actually present to you with symptoms of hypertension. When they looked at the diagnostic utility of the SFLT1 with the PIGF ratio, they took a cutoff of less than 38, and they saw that this actually helps. There was a study which was published, which actually saw that this had a high 80% sensitivity in helping ruling out preeclampsia in high-risk women when the ratio was less than 38. Some of the recommendations from the NICE, or like it's a European society, where it uses these PIGF-based tests along with clinical assessment between 20 to 37 weeks. But they say do not use it to guide timing of delivery. It should be more of a clinical decision. And then the ISSHP society also looked at the same thing, and they said that the higher the ratio, the more your risk. But it should not be used in isolation. Again, it's more a combination of that with your maternal risk factors and your clinical progression. Limitations are this test is not widely available. It's not globally as used, and there's no standardization for routine clinical use yet. Take home point again, you use this marker, but don't rely on it. You use your clinical judgment and obviously assess the patients as we go. This was one trial, which was a prospective interventional randomized clinical trial that evaluated the use of this ratio in women presenting with suspected preeclampsia. The ratio cutoff that they used to define as low was less than 38 and high as more than 38. And their goal was so they put them into groups where one group, the clinicians had access to this ratio for the patients, and the other group, the clinicians did not have access to that ratio. And they saw the primary outcome was hospital admissions, and they saw that there were fewer hospital admissions for suspected preeclampsia in the observed group where clinicians did have access to that ratio. So especially in the 24 hours and 7 days after testing, there was more utility of that. And the use of this test also avoided unnecessary admissions without really missing the true cases of preeclampsia. The secondary outcomes that they looked at was the time to clinical decision making, which was shorter when they had the biomarker available, so they were able to make the decision faster of whether we need to treat them or not. The length of hospital stay was reduced in the groups that they intervened upon, and there were no entries in the maternal or fetal outcomes with the use of this test, thus indicating it was pretty safe, effective. Clinicians reported greater confidence in their management decisions, and there was also a reduction in repeat testing and unnecessary monitoring in women who had lower risk. Some of the preventative measures that they recommend is weight and lifestyle optimization, preconception, and in between pregnancies, they recommend to lose weight. Lower BMI obviously reduces the risk of preeclampsia, like we mentioned earlier, because it's one of the risk factors. And then even in between pregnancies, if there's weight loss, even if you've had it before, you might still have a lower risk. And then during pregnancy, again, diet and lifestyle modifications. And then they did a meta-analysis where they saw 26% reduced risk for preeclampsia when these interventions were done. The other things that they usually recommend are the aspirin and the calcium. So low dose aspirin inhibits thromboxane A2, which spares the prostacyclin, thus reducing inflammation and platelet aggregation. According to the ACOG and the USPTF guidelines, they start at 50 to 150 milligrams, usually around 16 weeks, sometimes even earlier if they think that you're at higher risk. And then usually with women with chronic hypertension, CKD, autoimmune disease, multiple gestations, and more than one prior pregnancies with preeclampsia, that was effective. They also recommend supplementing calcium. And they saw that when they have a higher intake of calcium, there's a lower blood pressure or at least lower risk of preeclampsia in those women. And this was a meta-analysis looking at 30 randomized controlled trials where the risk was reduced by 51% in patients who did get calcium supplementation. WHO recommends 1.5 to 2 grams per day, especially in women with lower baseline calcium intake to begin with, or those who are at much higher risk of having preeclampsia.
Recently, I've heard that the aspirin recommendation, even for, how do they call it, older unipara or primipara or something like that, or is that not true for current recommendation?
So they already are at high risk. They already qualify for the aspirin. I just didn't include everything, but all the risk factors that I mentioned, these are the common ones that they see, but anybody with those risk factors automatically gets the aspirin, or at least that's what they recommend. Initiating antihypertensive in the pregnant women, the treatment of pregnant women with severe hypertension with severe features, there's consensus that when you have severe hypertension, meeting this one with severe preeclampsia with severe features, when your blood pressure is already more than 160 over 110, it should be treated within 30 to 60 minutes of diagnosis to reduce your risk of stroke, heart failure, and kidney injury, along with maternal complications. So I think that's something that they usually implement as soon as you go to the hospital, which is why I was emailing Dr. Ruchi to make sure if I should get the labetalol, because they wanted to give it right away. Within the first hour, they want to treat you because the risk of stroke and everything is much higher for the studies. When they looked at the retrospective report, this was done in California. blood pressure above 160 systolic was found in 96% of the maternal deaths and about 110 when it was more than 160 or 110, it was seen in more than 96% of the maternal deaths. And the diastolic was in more than 65% of the cases. Sorry. Initial blood pressure reduction should be restricted to 25% over the first 2 hours, as further precipitous lowering can compromise the uteroplacental circulation, like Dr. Siegel was saying, which is why they don't lower it too much too quick, like we usually do in stroke patients too. And then close monitoring must continue to achieve a target of 130 to 150 and 80 to 100 diastolic, especially for intrapartum patients. That was for severe preeclampsia with severe features, but what about those with mild to moderate hypertension? These patients, there's less uniformity. There's no like clear-cut guidelines of this is how you need to treat. The Cochrane review of around 63 trials, and there was a CHIP study that was done. They showed that aggressive blood pressure control prevented development of severe hypertension in the future. But again, it's different and different societies have different guidelines. There's nothing clear cut for these patients. It's just, they all recommend that you do it more as a more individualized treatment than guidelines. Like I was saying, the ACOG, the most recent guideline, they tell you when to treat, which is 140/90, like I described, but it doesn't tell you what the treatment target is, so at what point you want to treat them to. And then they recommend continuation of the previous antihypertensive after informed decision with the patient. The International Society for the Study of Hypertension, again, the cutoff is similar for all of the societies, but they do give a treatment target of targeting a systolic of 110 to 140 with a diastolic around 85 or below. The National Institute of Health and Care Excellence also gives cutoff, but it's a little different where it says 140/90, but they target less than 135/85. And then anything below that is okay for them. The Society of OB/GYN in Canada said 140/90, and then the diastolic for them was less than 85, but for chronic hypertension, it was less than 140/90 if they have comorbidities, which is interesting because ACOG says for chronic hypertension, they want to treat when it's, for chronic hypertension, their cutoff is higher, but for the Canadian Society, it's lower for chronic hypertension as compared to preeclampsia. And
I don't think any of this is based on good evidence.
true. Yeah, there was not a lot when I looked. And then the European Society again doesn't give a treatment target, but their goals again is treated if it's more than 140/90. And if they're chronic hypertensive, then they go a little higher and say it's okay till 150/95. And again, 140/90 if you have end organ damage.
The acute one, what is their pre-specified important measure? I mean, first of all, like the diastolic or diastolic, and second, where did the 25% recommendation come from? In the previous one, 2 slides back.
Oh, this was a retrospective report that they did, where this was done in California. I think they looked at, I don't remember the number of patients they looked at, but they saw that the maternal death was higher when the systolic was about 160 in almost 96% of the patients. So I think they came up with this recommendation.
This was, I think, only for patients who got stroke.
Right, this is like a stroke retrospective, pregnancy and
Right.
stroke retrospective analysis.
There, I think maybe they don't want to reduce blood pressure by so quickly.
Probably just in stroke.
It's just like for regular stroke patients.
Like the reason why I was asking, and just to clarify, is that like if you start treating everybody with 160 or 100, like, and that is what I was asking, which one of the two is important. But if you start treating everybody with greater than 160 with antihypertensive and start reducing by 25%, is there a possibility that you might induce one of the complications?
I guess they say you should restrict it to 25%. So I don't think they say bring it down all the way to 25. You shouldn't go below 25%. Like
These are very, but it's very loose, right? So
right.
OB in chronic hypertensive, OB doesn't like the blood pressure to go below 140.
Yeah.
They're concerned for concentration. They're working with them here. That's
Although the data that's been shown to be false. There's no danger going lower. I think it was a New England Journal of Medicine that had used the two different targets, 140 and lower than that.
Yeah.
But they're still just so conservative.
Like you said, there's not a lot of research in.
And I think people are scared to do it, because
Exactly.
to risk. Drugs, we know about the common drugs that we use for acute treatment. IV labetalol is always the preferred first line. Usually good efficacy, side effect profile, contraindication in patients with asthma, maternal bradycardia. IV hydralazine you can use if you don't respond to IV labetalol. They also do nifedipine if you're not able to get IV access. The extended or the immediate release 10 milligrams can be given, but with caution because they don't know how each person will react with the pill. And then you have to
2023 recommendation. So they use sublingual nifedipine or immediate release nifedipine still?
So I think it's only in patients where you can't get an IV access. They say you can, but I don't think people really do that. It's like the last ditch effort. If you can't get an IV, what do you do? Labetalol, again, you start at 20 milligrams gradually and then repeat blood pressure every 10 minutes, give 40 milligrams IV over 2 minutes, and then escalate it by every 10 minutes, escalate the dose till you reach your blood pressure target with a maximum dose of 300 milligrams. As an infusion, you can do 1 to 2 milligrams per minute after 20 milligram bolus dose, and then adjust the dose every 15 minutes to achieve a maximum dose again of 300. With hydralazine, they say start at 5, gradually over 1 to 2 minutes, repeat it every 20 minutes instead of 10, and then give 5 or 10 over 2 minutes. If still uncontrolled at 40 minutes, give 5 to 10 over 2 minutes, and then maximum dose is 20 to 30 per treatment event. And then the nifedipine, 10 milligrams oral can be repeated at 20-minute interval. Again, they say use must be limited only in patients with hypertensive emergency and you don't have any IV access. We don't know how the patients will show blood pressure changes with that. And then they also say there's some where they say you can use the extended release as well, but I wouldn't be comfortable. And then the maintenance therapy in patients who've already gotten their blood pressure controlled. With the labetalol, you usually start with 100 BID, increase by 100 over 2 to 3 dose, the maximum dose of 2,400 milligrams. But then there's the caution that there's rare cases of maternal hepatotoxicity that occurred with it. With the nifedipine, the extended release, they say start at 30 to 60, increase by 30 over 7 to 10 days, and then you can go for higher doses in divided doses to give a max dose of 120. And then methyl dopa is also used in some cases. Initial dose is 250, 2 to 3 times a day, increased by 250 over 2 days, max dose of 3,000. But it can cause sedation, postpartum depression, there's high risk of that. And with hydralazine, you start at 10 milligrams 4 times a day, increased by 10 to 25, and then max of 200. But it can cause reflex tachycardia, so it's better combined with beta blockers. All of them plus a placenta, there's limited data available on their efficacy and safety. But for the review, no evidence suggests that one drug is superior to the other. And then drugs to avoid, atenolol, they have decreased fetal and placental intrauterine growth restriction. Also secreted in breast milk, so they say to avoid. Propranolol is non-selective, associated with decreased fetal weight again and placental weight as well. We know we don't use RAS and renin-angiotensin inhibitors because of the adverse effects. Mineralocorticoid receptors, again, we know, especially in male fetus, you're concerned. I think we already discussed that in the last rounds. And then nitroprusside associated with fetal cyanide poisoning. So it can be used as a last resort in hypertensive emergencies, but you must restrict how long you use that drug for. And then, like I mentioned earlier, diet and exercise, salt restriction, no evidence to support restriction of physical activity if they have mild to moderate hypertension. So they don't need to be like bedbound or anything. You just have to make sure you monitor their blood pressure and they have frequent follow-ups. But patients with severe features, when they reach near term, they might actually benefit from rest to improve the placental circulation and also to prevent exacerbation of the blood pressure. Other consideration in management of pregnancy is delivering the placenta, which is the only definitive treatment in preeclampsia. It needs to be individualized based on the age, the blood pressure, the maternal and fetal conditions of when you want to deliver. When they have severe features, though, the indication is to deliver right away. So if you see somebody with severe features, there's no questioning. We can wait longer or not. They say you should, because the maternal morbidity is much higher in those patients. Otherwise, if you decide to wait when they are mild to moderate, you need to monitor the labs at least twice a week, make sure their renal function's okay, look at the CBC. Fetal monitoring by daily fetal movement counts, NSC and biophysical profile at least twice a week. And then if they're less than 34 weeks, then they benefit from betamethasone injection. And then for seizure prophylaxis, the magnesium sulfate is what's studied in the randomized studies. I think it was a MACPI trial. It's effective in prevention and treatment of eclampsia and also in women with preeclampsia with severe features. So they recommend treating those patients as well. In the meta-analysis and the randomized studies, they saw that Maxulf was safer and more effective than phenytoin, diazepam, and the lytic cocktail for eclamptic women. So it was proven to be superior to all of that, which is why that's the current recommendation. It does not prevent progression of other end organ damage, but that's not related to seizures. So the goal of using that is only to prevent seizures, not prevent, like, it doesn't affect your other end organ damage that might happen with the preeclampsia. The role of seizure prophylaxis in patients with preeclampsia and without severe features is unclear. So they recommend you see the patient, individualize it, but it's not recommended, And since it's renally excreted, if they have reduced GFR to begin with, you want to be more cautious with signs of toxicity. Postpartum management, BP usually tends to reach preconception levels by 6 to 12 weeks. If they persist beyond that, then it qualifies as chronic hypertension. 20% women with postpartum hypertension within 6 weeks of delivery showed transient hypertension from volume changes like using NSAIDs for the pain management, especially in patients who underwent C-section. All the patients need monitoring for end organ damage, like even postpartum. So for the first 6 weeks, you have to watch them for headaches, blurry vision, abdominal pain, epigastric pain. Target blood pressure is similar postpartum to the general population, but again, if you think they're at much higher risk, you want to individualize them and treat them more specifically. And then lactation safe drugs, if they're breastfeeding, nifedipine, labetalol, lisinopril, and metoprolol are all safe, what they say. Preeclampsia is associated with increased risk of ongoing kidney injury, and thus you need to make sure even in the postpartum phase, you monitor their kidney function and look at creatinine and the GFR. In conclusion, management requires multidisciplinary management. Women with hypertensive disorders of pregnancy should be counseled about the postpartum increased risk of all cardiovascular and kidney disease, and timely diagnosis and optimal management is essential to improve both fetal and maternal health. And that's it.
So that was really nice overview. The other thing I'd just like to stress, I think when I was in training, we sort of learned that HELP was just more severe form of eclampsia. And there was a study maybe 10 years ago, I don't know if it's been followed up, that looked at complement variants in people with HELP. And they found complement variants in about 50% of those with HELP. So and remember, in atypical HUS, you find it in only 50%. So likely HELP is preeclampsia on top of a variant in the complement cascade leading to this, right? And it makes sort of physiologic sense with what you're seeing. So that was a great talk.
I'm just wondering, I don't know if you know, or just wondering about the S-split and the EIGF ratio. Is this like and I don't know, maybe in the US we don't do that. I don't think. Is it like an office test, like you can do in the office point of care?
He does have one, yeah, point of care, yeah.
Chance takes 5 to 7 days.
I don't,
From the last two that I ordered.
Yeah.
It's expected to be helpful, but it's not helpful.
Yeah, we got one inpatient too, but it took forever and the patient was discharged by the time we got it.
That will be helpful. And then also to your point, like in the situations where S-split the IGF is helpful to rule out preeclampsia, maybe there are false blood pressure elevations that are just measured in the clinic and
Right.
it could be avoided just by having a protocol to check that, maybe like starting in 12 weeks.
Yeah.
At home.
Some protocol.
But that won't capture a lot of the people who are at risk, because a lot of the, high risk populations don't have access to
no,
blood
they're
pressure,
not.
they just don't have the bandwidth to check
That's
their
why
blood
it's actually
pressure. or-
Yeah.
Also, it comes out of nowhere. You have like normal blood
Yeah.
pressure and then one day it's like one, two, three, like
And
one
when you're in the hospital and the
day.
babies are coming down.
Then, just an interesting to add on your list of risk factors under moderate risk, you mentioned African American race. So we know that the placenta does express APOL1. So that's probably something that, we're going to be researching and looking more into what the pathogenesis of that is. And if there's a way to kind of stratify these high risk allele patients, for, treatment and prophylaxis. More to come on that, I'm sure.
Like them, I also don't have data for this, but the hypertension management, I think it still is from the vantage point from OBGYN that it's written. And I think we do need to, especially when we get involved, I think there is a little bit need for modulation of both the aggressiveness with which they require treatment and the non-aggressiveness with which they manage. So like they try to go heavy-handed and pretty rapid, and then they are not really comfortable with really controlling blood pressure. And I think, and that's where you see their reflection of a lot of short-acting vasodilatory agents. And they have an unusually high level of comfort with these agents compared to all of us. Probably because they are safe in pregnancy, quote unquote. So I think when we are involved with, I probably would caution against it. I think I'm not sure that most of the time when they're defining the 160 or 110 acute, whether an extended release nifedipine will not be the right choice because the onset of action is fairly rapid. It just is not within minutes. And so, you have to titrate the acuteness a little bit. But that's what I commonly do because I'm not sure that I would give somebody sublingual or short acting unless there is a real life threatening something I'm not able to handle with any. Like I don't even know whether I would even in that situation.
It's like a last ditch effort when you don't have any IV, you can't do anything.
Yeah, but that's not present. This was one of the 4 agents presented for them. You see my point?
Right.
Like the level of the vantage point from where they are coming, it sometimes is highly uncomfortable for me to practice as a reasonable physician. It was great talk. All right.